everybody. Hello, and thank you for joining us today for the fourth Texas Covered Forum, Healthcare Innovation in a Time of Crisis. My name is Jason Baxter, and I am the Director of Government Relations with the Texas Association of Health Plans. Our first panel today is on individual coverage health reimbursement arrangements, or ICHRAs. Please remember, if you have any questions today, please feel free to type them into the Q&A box, and I will look at them and ask some of our panelists. Before we get started, I'd like to introduce our panel this morning, and then we'll begin. Jack Cooper is the founder and CEO of Take Command Health. Prior to founding Take Command Health, Jack spent 6 years as an analyst at the CIA and FBI, helping top officials unravel data to understand risk and opportunity. In addition, he has management consulting and strategy experience with the Boston Consulting Group in Dallas and project management experience with Shell Oil Company in Houston. Good morning, Jack. Also, we have Tamara Ward, who is the market leader and regional vice president for Oscar Health. Tamara is responsible for building Oscar's footprint in individual, family, and Medicare Advantage lines of businesses throughout Texas, Kansas, Missouri, Oklahoma, and Iowa markets. Prior to joining Oscar Health, she spent over 14 years leading payer-provider partnerships, operational turnarounds, population health, and direct-to-employer strategies for health systems, payers, and clinically integrated networks. And she's going to give us the carrier's perspective this morning. And last but not least, we have Randy Pate, who will be our first presenter. Randy is a CMS Deputy Administrator and the Director of the Center for Consumer Information and Insurance Oversight. Randy leads CMS's work on the individual and small group markets, including the health insurance exchanges. Prior to joining CMS, Randy was Vice President of Public Policy and Healthcare Services Corporation and spent nearly a decade working on Capitol Hill at public policy think tanks and in the executive branch. Randy, do you want to go ahead and start?
Absolutely. Jason, can you hear me?
We can.
Excellent. All right. Well, good morning, everybody, and thank you so much for jumping on here. It's great to be part of this panel. We got a lot of great fellow panelists here, and I'm excited to hear from them. I'm going to share my screen real quick to go through my presentation. See if I can do that. All right, and then. Does that look okay?
You look good.
Great. All right, so the topic today is the individual coverage HRA, and I noticed the title of the presentation was, it's a new HSA, and so, there's a lot of acronyms in this space, obviously. So we're talking about ICHRAs, EBHRAs, QSEHRAs, HSAs, and then you got your regular old HRA, right? So there's a lot to sort of parse through when you think about all of this. I work at CMS, and you guys know if you're involved in healthcare or healthcare policy, we use a lot of acronyms. We had an employee come over from the Department of Defense to CMS and was like, "Guys, you use a ton of acronyms, right?" So we're pretty guilty of that. But I want to try to demystify this individual coverage HRA, especially in terms of the final rule that the Trump administration put out in June 19. So HRAs have been around for a long time, and really it's an arrangement. It's not necessarily an account, but it's a way for employers to, through the arrangement, provide funds to their employees to pay for healthcare expenses. So they've existed for years, but what really happened in the June 2019 final rule that was put out? It was put out by us, CMS, the Department of Labor, and Treasury jointly. Is it really created a new pathway for employers to provide their employees with a defined contribution arrangement for them to buy individual market health insurance coverage. And so, we get into the slides here. So just defining what an HRA is, it's a group health plan, and it's funded solely by employer contributions, and it goes to reimburse the employee's medical expenses. And that includes both premiums or out-of-pocket costs. Now, one of the big advantages of an HRA generally, and in this context, the individual coverage HRA, is that it's tax advantage for both the employer and the employee. So the June 2019 final rule really provided this pathway to say, in this individual coverage HRA space, when the employer provides funds to the employee in this ICHRA, and then the employee goes to buy individual health insurance market coverage, that constitutes a group plan that will satisfy for example, the ACA's, employer mandate. For large employers, the mandate that they have to provide coverage that meets minimum value and affordability. And so we can talk a little bit more about that, but it also means that the individual coverage HRA can be used to pay premiums and out-of-pocket costs for Medicare enrollees as well. So that's an additional benefit. So this final rule came out in June of last year. It really launched in terms of being in effect January 1st, 2020. And so we have seen people, and Jack and others can tell you about folks that they've enrolled and employers they're working with who are in these plans already. But just to give you a little more of an idea of how it works. So when you talk about individual market health insurance coverage, you're talking about exchanges in every state. There's an exchange, and there's premium tax credits available through the exchange for people who purchase their coverage through that. So the way this rule works is you cannot get premium tax credits if I'm an employee, I can't get a premium tax credit, go to the exchange and qualify for one. As long as my employer is offering me an individual coverage HRA that meets affordability standards, which is the lowest, the premium for the lowest cost silver plan, in my particular service area. So the other piece, when you think about the individual market, is there are rules around the open enrollment period and special enrollment period, just like in the group market, in terms of when you can get in. So we also created a special enrollment period for employees and their dependents to come in, who are newly gaining access, whether it's because they got hired or because their employer group plan calendar doesn't line up with the individual market open enrollment. So just a little more detail here. There's a lot of complexity. It looks like a lot of complexity, but what we really tried to do is create flexibility within the context of preserving the single risk pool in the individual market. Because as many of you know, the ACA creates a single risk pool for the entire individual market within a state. And so we had to sort of create some guardrails to make sure that we preserve that risk pool and make it basically make it affordable and attractive, to employers to continue to send their employees into the market. So to do that, the HRA has to be offered on the same terms to all individuals within a class of employees, except you can vary the amount of the ICHRA offer for older workers or workers with more dependents. So that makes sense. So they can be able to afford, they're going to pay higher premiums. But so in general, you can't offer both a traditional group health plan or a choice between a group health plan and an individual coverage HRA to any class of employees. So you can't sort of offer that choice because that is a sort of adverse selection issue for the single risk pool. So what classes can you offer ICHRAs to within your employee population? So you can offer it on full-time basis, part-time, seasonal. So your full-time employees could have a group plan. Your part-time employees could have an ICHRA, for example. Employees that are covered by a collective bargaining agreement. So union employees, salary or non-salary, you can split it up that way. You can offer one separately to employees who have not satisfied a waiting period. Also non-resident aliens with no US-based income, and you can vary it up by employee work locations. For example, if you have employees in different states. So in terms of the benefits, it benefits employers in a lot of ways. It's defined contribution. So it's you're providing a lot of administrative relief, to companies who are not having to sort of, have in-house or, a lot of effort to, choose a health plan for their employees, and it's cost predictability as well. And when you look around the country, depending on the state of the individual market, there's an opportunity for employers really to save a lot of money on their benefits by going with an ICHRA. And the other big thing is you're not having to pick a single healthcare plan that works for everybody. So that's another benefit. and there's no participation rates issues like there are in a lot of the small group plans. And then, I think we'll talk about the greater benefits of this, but certainly for employers, you can offer coverage to maybe groups of employees you never did before, including your seasonal or part-time workers. From the employee side, you get choice. You get to go out and pick your own healthcare plan on the individual market. So, as long as the market in that area, offers a good choice of plans, which, the choices have been increasing over the last few years, that's a real benefit. Also, just like we talked about above, if you're part-time, and or seasonal and your employer is offering it to you, for you, it's a new opportunity to access coverage. And then finally, the portability issue, which is obviously, a big thing in employer sponsored coverage in general. If you lose your job, you lose your coverage. Here, at least you have the ability to stay enrolled in that same plan, as you move from job to job. And so, especially if you move from an employer that has an ICHRA to another one that offers an ICHRA, that's a seamless move for you in terms of your health benefits. So we've done a lot of outreach at CMS over the last year or so on this. We hosted a big industry day back before the pandemic kicked off in January at the department. And we've done a lot of webinars. We're trying to get the word out about this option because we think it's a very exciting option for both employers and employees, and also we think for the individual market. And I'm going to provide you some links to some resources in the last slide, and hopefully we can get that information out to y'all. But one thing we've done on healthcare.gov, which is the exchange that we run in 38 states, is we have sort of adapted our online application to screen people, who are coming to the exchange and maybe, they don't know that they're, for example, firewalled, prevented from getting the premium tax credit, if they have an affordable offer of coverage through an HRA. So we're now screening for that through the application process. It's pretty seamless. So we'll identify people who, hopefully have an ICHRA, and then we can steer them to the non-subsidized coverage so that they don't run afoul of those rules. Now, you can buy these plans, people can buy these plans off exchange. They can use a web broker, they can use lots of different channels, but we have really tried to make it simple on healthcare.gov so that people really know what they're eligible for and what they can buy. So this last slide here just gives you some links to some of the resources that we've put out, and hopefully, Jason, we can share that with folks afterwards so that they have it. But with that, I will conclude my remarks. Thank you.
Thanks, Randy. Yeah, all these presentations are going to be posted on the website, so they should be available for everybody to look at when we're done here. Thanks, Randy. That was very informative. Next, we're going to hear from Jack. We're going to hear about his work at Take Command Health and hear a little bit about some early adopting experiences.
Hi, Jason. Hi. Thanks. I want to thank TAHP for having us on today, and Randy for kind of kicking us off. I'm going to pull up some notes here that we can share. So Take Command Health, is that coming through for everyone? Just verify before I start rambling on. So Take Command Health, we're an ICHRA administrator based here in Texas. We combine kind of an HRA administration suite that was really designed from the ground up for these types of HRAs, as well as a private shopping experience for employees. So I want to walk you through what we're seeing and talk about how, as carriers, some early insights we've seen so that maybe you can take away and think about, all right, how do we position ourselves to win in this new market? I think the first thing to understand is that this is a new model of insurance, as Randy kind of walked us through and explained. And when we typically think about employer insurance, we think about the group model, where I'll pick on Blue Cross a little bit here, just because they do so many small groups, but you sell a plan, to the employer, and all the employees get that plan as well. Well, ICHRA is different because, as Randy mentioned, now employers are going to give money to employees, and employees will be making the decision. So in this case, if you're Blue Cross and your group transitions to an ICHRA, you may sell some of the individual plans, but they may adopt other carriers as well. So how do you stand out when the employees are making those choices? That's what I want to talk about today here in a few minutes and share some early insights that we've seen. So the first thing to realize is that this really is a new market. If Randy and CMS and others, have projected that this is roughly going to double the size of the individual market in the next few years. There's some reason to believe it could actually be higher than that. But the reality is these are not individuals, that are shopping on the exchange, that are getting tax credits and subsidies. These are business employees that work at small and medium-sized firms. They're interested in other things than individuals that might be shopping on the exchange. So I think that's the first insight is just realizing, all right, the individual market's going to double, but it's not the same individual market. You're fishing in a different pond, and that may influence plan design and positioning. So as I mentioned, Take Command is an ICHRA administrator. We have about 500 clients nationwide on actively using ICHRA, including over 100 in Texas. So what do those look like? They come from all industries and all shapes and sizes, but wanted to pull kind of the most common ones that we see, just to put a little color and life to it. So the top industries we've seen move over to this model: nonprofits and association groups, software and technology, especially ones with remote workers or distributed workforces. ICHRA provides a lot of flexibility, geographically. Home health, which has been interesting. Typically these groups are very hard to insure with the group model. You may have 100 employees and 10 of them are full-time staff, and then you have another 90 hourly field workers, and that's really hard with the group model to manage participation and things like that. With ICHRA, that's not as big an issue. I won't read through all these, but healthcare providers, financial services, a lot of different groups that are moving over. What's been interesting is the size of groups coming in. We're seeing a little bit of a different kind of divergence. A lot of small groups and kind of the 1 to 10, which we'd expect. We call those groups looking for the on-ramp to benefits. But then a surprising number of ALEs or applicable large employers in that kind of 50 to 200 range. Randy mentioned some of the design classes that they can use. We are seeing those adopted. A lot of the common splits include full-time versus part-time, hourly versus salary, or location. Here's a quick snapshot of the sizes of employers we're seeing. As I mentioned, a lot of small groups. This blue and orange is 1 and 2 to 5. What's been surprising to us is the growth in these large groups. And if we looked at the actual number of lives that have come on, this purple bar really takes over just because those employers are so much larger. This is the key slide I really want to communicate to carriers. A lot of folks immediately see ICHRA and they start thinking it's a zero-sum game where it's like, oh, all right, that's interesting, but I'm a little nervous about it because if I support an ICHRA, that's just going to wear down my small group plans and I'm going to lose that business, or now I'm possibly sharing that business. This is a key insight that I think is really important to understand, especially in Texas where we have so many small businesses. When we look at small employers that have adopted ICHRA, now for us, we define that as under 10, over 70% are new to benefits. So these are net new lives being added into the insurance market that were not there before. And that makes sense, particularly in Texas, where you look at the small group insurance, coverage. How small groups offering coverage has declined steadily in the last few years. A lot of that's because of cost, and a lot of that's just because of the model, where they can't find something that fits because of participation or something like that. So this is huge, and I think something that if you're looking for opportunities to grow, here's a great opportunity to grow. With larger employers, as you suspect, we do see some more cannibalization, from group plans, but still almost 40% are net new to business as well. So very exciting. All right, so how do I win? I've got 1 minute to kind of share this slide, and this probably unpacks a larger conversation. But you've got to think about now the employee experience. So this is a mock-up of a shopping experience. It's not real. I pulled in Oscar and Cigna just because I know Tam's on the line here and presenting next. But just want to present a scenario to you of how an employee may be shopping for insurance. So in this example, John, an employee, is being given $300 a month by his employer. And as part of the ICHRA rules, he has to be able to see every plan in his area. So imagine the screen went down and has, plans from Oscar and Cigna and Blue and whoever else is in that market. We get a lot of questions from carriers about, hey, can I show an ICHRA with just my plans? And the answer is that's would go against the regulations. So you got to find another way to stand out and win. And I think this is kind of hints at what that could be. So let's say John, he's looked at all the options, but he's down to a bronze plan between Oscar, that's off exchange, which is important because of some tax rules, and Cigna, which is on exchange. They're both $450 just to hold kind of things constant. What's interesting with the off exchange play, and I'm sure this is going to bring up a lot more questions, but happy to talk through another time, is that can actually be deducted through his payroll using a Section 125 cafeteria plan, which gets all complicated in the insurance language, but the practicality for John is very obvious. He's getting $300 from his employer. He wants a plan that's $450. So to make up for that difference, he can pay $150 out of his paycheck, tax-free, to cover that difference and secure that plan. If he wants the Cigna one, because it's an on-exchange plan and because of some some tax rules and regulations, okay, he's going to take the $300 from the ICHRA, but then he has to pay $150 out of pocket after tax to make up that difference. So again, we get all like kind of down in the weeds of the insurance rules and regulations, and happy to unpack this more, when we have more time. But some real obvious things, again, not trying to pick on or highlight Oscar and Cigna here. This is a fictitious scenario, but you can tell what John's going to, be inclined to choose in this case. A few other things is if you're a carrier, thinking about designing from ICHRA, based on some early trends that we've seen. As back to that initial chart, right? This is a different market. It's individual, but it's employees, and so they value different things than true individuals, shopping on the market. They're not eligible for tax credits, so they, as much as we love Randy and CMS and healthcare.gov, they don't want to go through healthcare.gov. Where a lot of plans have silver loading and other things that are designed for subsidies and tax credits. They want to pay for it with payroll, which means it's got to be an off-exchange plan, and then maintaining access to their doctors. We get a question a lot of times about, well, what's a good enough doctor network? What does that look like? We don't, especially in Texas, we know there's no individual PPOs on the market, and we don't expect those to come back. But looking at broader options that are a little bit more inclusive, broader EPO or ability where we call in a market where they can pick their own team. And most of the markets in Dallas, support this. And then some plan structure ideas, and kind of a fascinating move. They really like the higher deductible minimum premium plans. The reason is if they're being offered $500 through an ICHRA and they can get a plan that's less than that, any amount that's different they can use on medical expenses. So it provides some spending power. So we love the idea of getting those kind of true catastrophic plan that's less expensive, so they have more room to spend. They love HSAs, employees do. And then, we think that because of these off-exchange issues, it's important to think about as a carrier, maintaining a true off-exchange portfolio. All right, that was really fast, and I'm sure it brought up a lot of questions. Happy to reflect on it when we get to the Q&A.
Thanks, Jack. Let's see, I've got a question here from Ken. I'm a big fan of supporter of the concept of defined contribution, but as Jack points out, all of the ICHRAs, ICHRAs, sections, 125 rules, et cetera, is more complicated than it should be. How can health plans take command and others work with CMS and others to make it simpler? we can go ahead and take that question now, I guess.
So I can answer from kind of the admin side. You know, and this, I think the first step is just realizing that it is complicated, but it can be a really different experience for employees. So the first thing is really looking at, if I'm on the care side, or what I would suggest is, you know, really looking at your off exchange portfolio. You know, there at the beginning of ACA, there was a pretty robust, you know, off exchange market in some areas. Now that's gone away, or they're just, you know, mirror copies of on exchange plans. And some states require that, but in Texas, there is more flexibility. And so looking at, hey, can we offer something that is going to be more appealing to a small business employee, not necessarily someone that's looking for a tax credit or an individual. And then I think secondly, you know, working with administrators like us, you know, not trying to highlight take command, but you know, there's more of us out there emerging that, you know, hey, we need to be able to make payment or direct payment, you know, to you. So having those kind of systems and integrations in the background, where we can help the customer and the employee understand what's happening and make that transaction really smooth, would be really helpful.
Okay, thanks.
And I'll just add to that real quick from the CMS perspective. So, you know, Jack, everything you said in your presentation is right in terms of, you know, if you have an ICHRA, especially if you have a Section 125 plan, you don't really want to be going to the healthcare.gov exchange, because we're all about premium tax credits, right? You can buy coverage that's not subsidized, right, through the exchange. You can do that, but, you know, that's why we've had to sort of be carefully build these questions in the application and so on, so people don't get that mixed up. But what you also pointed out, and I think the questioner is pointing out, with the Section 125 plan, that is something that is in the IRS code that says if you have a Section 125 plan, you can't buy a plan on the exchange, period, whether it's subsidized or unsubsidized. So I think, you know, the answer to that, partial answer to that, is that Congress, you know, it'd be great if Congress could change that statutorily so that we could fix that. And the other thing I would say is, you know, we have been at CMS, we have been working really hard to start something we call enhanced direct enrollment. So there are web brokers out there who are selling, you know, they will sell both on and off exchange, you know, coverage, and they're not bound by the same rules and restrictions that we have on healthcare.gov. So those are options for people to go have a nice, you know, hopefully a nice user experience, see all the plans and be able to compare their options.
Okay, excellent. All right, sorry about that, Tam. Do you want to go ahead and talk a little bit about Oscar's experience and the carrier's perspective before we go to the rest of the questions?
Absolutely. Thank you, Jason. And I promise I didn't encourage Jack to highlight Oscar in any way today, but thank you. As Jason shared, my name is Tamara Ward. I'm the VP for Oscar here in the market. And as we think about ICHRAs and the opportunity that they provide to offer different types of coverage for both employers and their team members, we believe that it really helps to support the idea of choice. And as health plans, we've been disrupted many times. If you think about times where we, you know, a huge portion of our business was really fully insured. And then as employers look for more innovative, cost-effective ways, they started to enter into more plans that were self-funded. We see ICHRA as a downstream evolution of the same level of disruption, that team member healthcare expenses are usually, right, the top expense for any business, especially a small business. And as we are coming off of, or really in the middle of a public health crisis, many small group employers are figuring out, one, how do they bring their team members back to work? But then two, how do they provide healthcare that is dependable and affordable? And this model, we get it, will not work for everyone, but we believe as health plans, we need to be able to offer a menu of options and solutions that will help support the employers in our community. And so if you think about the competitive landscape of recruitment, if you think about how team members are now very mobile, living in different parts of the country. ICHRAs offer that opportunity to retain and attract team members by also offering the right level of flexibility and coverage. And what we believe is that the coverage under this model is much better than some of the catastrophic plans that are out there. And it gives team members transparency. It allows them to understand what they're signing up for, what services truly will be covered. And then if you think about the extra service that health plans offer, it kind of gives them a community to help guide them through their healthcare journey. As we think about, and I think Jason brought this up earlier, cannibalization of our existing business. We're of the mindset is either you be a part of the disruption or you get disrupted. And so as our employers look for different solutions, we need to be there and be innovative to be able to provide those solutions. I know one of the questions that was in the chat was related to kind of some of the complexity. We also, I think from a health plan perspective here at Oscar, believe that we have a duty to make healthcare easier, right? To make it easier to find coverage, to make it easier to figure out what plan works best for you. Some of that happens through partnering with certain administrators, and some of that is the onus of us as health plans to make finding the right coverage and the right plan easy, simple, and also affordable.
All right, thank you. We'll get into some questions here. First question I've got is for Randy, and I think you talked a little bit about this in your presentation, but what are the most important aspects in your mind of the final rule that issuers should be aware of?
Yeah, I mean, I think, well, and I think Jack is really hitting on the business side of it too, and sort of the strategy along with this. But, I think just learning the rules around what's possible. I mean, on the issuer side, you're really just designing the products and putting them into the individual market, right? I mean, I think there's an adjustment that's going to happen with that. But, all the rules I talked about surrounding the firewall with the tax credit, surrounding the classes, the employee classes, I think those are real important. There's the substantiation issue, which I didn't talk about, which is, when the employer offers an ICHRA to me as an employee, I go and buy my coverage on the individual market. I've got to, there's a form you basically have to fill out to substantiate that I've actually enrolled in individual market coverage. There's the noticing requirements. So there's a lot of complexity around this. But, I think, over time, hopefully, in companies like Jack's and others, are going to help, and Oscar and all the players are going to help to simplify this. But I think, just learning those rules, because we really are at the beginning of how this all works, I think is real important going forward.
All right, thank you. Anybody else have anything they want to add, our panelists?
I'll throw, back to kind of build on Randy's note about understanding the rules. Some carriers that won't be named, they've see, okay, hey, here's a new thing, and it kind of funnels down their legal department, and then they realize, all right, we should have something for this, so they go through the RFP process, and they're thinking about it like a traditional HRA or an FSA or HSAs, where you're going to have these account-based things, attached onto other plans. We get a lot of questions from carriers about, can I do an ICHRA that only shows my plans? I mean, that makes sense from a business standpoint of why would I want to offer, just since Tam's here, why would Oscar want to offer an ICHRA where people could choose Oscar and Ambetter and Cigna and Blue Cross? And it's, some of the carriers we've seen have really clued in on that and been like, oh yeah, that doesn't make any sense for a carrier to sponsor an ICHRA. But it does make sense, as Randy pointed out, for them to know the rules and know how to compete in that sort of environment. So I think that's the biggest thing, is, as Randy said, know the rules and don't try to bend it, because that takes away the choice, that takes away the flexibility, and really the value ICHRA is supposed to bring to the employer if we're just offering it with one set of plans on there.
Sure. That kind of leads me to one of the other questions I had. And you can answer this one, Jack, I think. If the tri-departments were considering updates to the final rules, are there any changes that you would encourage engagement between issuers and community employers to promote ICHRAs?
Yes. Yeah. So Randy brought up a big one, and that is this kind of funny on exchange, off exchange difference. As he mentioned, there's some legacy tax codes that prevent on exchange plans from being used in the same way that off exchange ones are with the cafeteria plans. So that would be nice to be fixed because it creates a little bit of extra confusion. The other big one we'd love to see change is there's a 90-day notice requirement for ICHRA, which doesn't line up with the individual market enrollment. You know, we've seen it kind of artificially punish employees where it's like, you know, I think it was designed as an employee safeguard, right? Where you can't launch an ICHRA tomorrow and now all of a sudden your employees, you know, don't understand what's going on or something like that. So we get that. We don't want to hurt employees. But it's also kind of funny, especially with these small groups. You know, if you think about a 5-person nonprofit and they're all right, hey, we're really excited to provide benefits. We want to give everyone $400. And it's kind of funny where it's like, great, you got to wait 3 months. It doesn't make any sense. That's not helping employees at all. So there's varying degrees of civil disobedience around that rule. I'll leave it at that. But I think that's a big one too. We'd love to see changed and smoothed out.
All right, thanks. Tamara, question for you. How can issuers ensure they are best positioned to respond to growth of ICHRA, the ICHRA model in their market?
Yeah, I think as we think about kind of being prepared for the market and what the market is really willing to bear, you really want to make sure that the benefits are competitive and they align with what consumers are looking for. It's similar to small group plans. So it's not a one size fits all solution. I think it's important to do the proper due diligence to ensure that, you know, we are working with the right ICHRA platforms for off exchange enrollment and integration to ensure, you know, that the frictions aren't there, that it's a seamless experience and very easy for folks to sign up for insurance through that mechanism. We are also at Oscar discussing what opportunities we have to streamline the payment experience, right? So folks want to be able to pay for this in an easy way that is consumer friendly, an experience that mirrors what they have today with their small group plan. So if you think about the experience that many plans offer today for both small and large group, and we'll say very personalized concierge-like experience, we should be really prepared to offer that same level of experience and consumer-driven focus on the ICHRA plans as well.
Thank you. Another question for you. What is the value proposition for issuers as related to ICHRAs?
Yeah, I think, you know, I shared a little bit of this earlier, and I think Oscar's position on this may be a little bit different than our peers, but what's really reality for us is that in our current environment, we need to have flexible options and many tools in the toolbox to offer our customers and our folks within our communities. And we know that small group employers, like I shared before, are going to be looking for alternative solutions. And although there can be opportunities where this can cannibalize your existing business, it also is an opportunity to retain existing business as small group employers are determining whether or not they keep, you know, health plan benefits or not. You know, the federal government's own statistics are showing that, you know, the individual insurance market space will grow over the next 10 years. The growth that Oscar has seen in particular, especially in the state of Texas, has also shown that the individual market space is growing. And so I think, you know, our industry is looking for things that are more consumer friendly. They're looking for more options. And as a health plan, there is value in us being able to have those type of solutions.
All right, thank you. Jack, I've got a question for you. What should issuers be doing now as they prepare their plan filings for plan year 2022?
great question, and excited to hear if folks are kind of thinking ahead. I know with the planning cycle, it's tough where we're going into open enrollment for 2021, and it's already time to start thinking about 2022. But back, I think one thing to do is as Randy mentioned, like know the rules on ICHRA. But then I'd spend some time thinking like, what is my ICHRA strategy? And what is this? We're already seeing it. It's very early, but we're already seeing some traction in Texas. If we assume that when we're looking at open enrollment, this time next year, ICHRA's grown in traction even more, how am I positioned for that? Am I creating off exchange plans that small business employees are going to want? Am I bringing back HSAs to some of my lineup? Am I working with administrators that are promoting ICHRA to have smooth connectivity there? I think those are the things I'd start looking at, and it's probably very different. I think most carriers, if you look at their P&L or their organizational structure, if they're either all on group, or all on individual, and ICHRA is a little bit of a unique thing. It's the individualization of the group market, and so it might be carving off a small team to think about, okay, we're selling this to employers, or employers are buying this, and employees are choosing. Do we have the right plan and structure in place to be able to win in this market? So again, that's a non-carrier, sharing, information, to carriers. I know it's much more complicated than that, but it is, I can just share from experience. It's funny when we talk to executives at health plans and they get all excited about ICHRA, and then they refer us down their small group management chain or their individual management chain. And, the individual guys, they have no idea what we're talking about. And the small group, they don't get the individual, and it does take a little bit new way of thinking, which may take a little bit of effort to bring that forth.
As an executive at a health plan, Tamara, do you have anything you want to add to Jack's thoughts?
Yeah, I think what Jack shared is spot on, in that we have to develop a unique solution for this market that is different than small group, different than individual, but somewhere in the middle. And so as we look at benefits, as we look at plan design, we have to take both of those line of business into consideration to figure out what works. And I think partnering with good brokers in the market, good administrators in the market to help have open dialogue on what the right solutions are is the first start. But then also listening to our customers. So understanding what folks that are shopping for ICHRAs are really looking for, what benefits really resonate with them. What are they looking for from a customer experience perspective? There may be things that we think are awesome and amazing that aren't of value, right? How engaged are they in virtual and in telehealth services? How engaged, or how much effort do we need to put into disease management and some of those other things that come with, providing health plan services. And so I'd say it starts with taking, I think, an innovative approach to finding the right solution. Two, I would say we really need to collaborate and hear the voice of the customer, both from the broker and the administrator, as well as the individual shopping in this space.
All right, thanks. Randy, a question for you. In what ways might ICHRAs transform the health benefit landscape in America?
Yeah, it's a great question. And so I think when you think about the individual market, and Tam, you just hit on it, you think about the coverage offerings maybe changing, to suit a different customer base, right? And I think that's part of it. But then you think about, what does that really mean if you kind of have this hybrid market, right, where you've got employers with sending their employees, and you've got self-employed people, early retirees, entrepreneurs, this sort of mix. And so it really is an interesting future, I think, that we have for the individual market, because it really can become, right now, today it already serves so many disparate types of people, and it's going to continue to do that and grow. And I think that's only going to make it more sustainable, more attractive, and it's going to make it work better over time. And then I also think about the portability factor, I think that is a real drag on our economy. The fact that we don't have portable health insurance in this country, right? When you change jobs or you lose your job or you stay home to take care of a loved one, you lose that coverage. And so, and I think that keeps people in jobs, longer than they maybe would be a lot of times. So I think it's good for the whole economy if we have that sort of robust individual market where, you've got portability, you have choice, you've got a lot of different options for people. So, I think that's really the transformative, promise, hopefully, of all this. As we're still very early, as Jack says, we're still in the sort of baby phase of this, but in the next few years, hopefully, we can really start to see some of this take off.
Thanks. Jack, do you have anything you want to add to that, or?
Sure. Yeah. And there's scenarios where, ICHRA, hey, it's just kind of a new thing and it helps become a Band-Aid for some groups that have struggled. And I saw a question just come in on the Q&A about, what percentage of employees, are getting an ICHRA now. It's tiny. It's got to be less than 1%, probably a couple thousand lives in Texas at most. But what does that look like going forward? And the projections are in 5 years, it could be as much as 50% of the individual market. What we're seeing, and I think a group that we forget about a lot, is the employer and their decision-making. We in the healthcare industry, we get all excited about the plans we design and the solutions we create. But the reality is when we sit down and talk to employers, right, they don't want to manage health plans. They're tired of making decisions, and it's the renewal is the worst 2 weeks of their life, where they're used to just getting bad news and they don't get it, and it's another 8% increase. If the shocking thing with ICHRA is it allows them to not make that decision. They can say, yes, I want to provide a benefit, but I'm taking this mantle of responsibility off, and I'm going to give my employees more choice. And I think it surprised a lot of our broker partners, surprised us a little bit, that once employers got that, how quickly they were willing to transition to it, as long as the individual market was good enough. But then you think about the snowball effects where, okay, we get a few, thousand more lives into the individual market in Texas, and there's small business lives, which, categorically might be a little bit better from an actuarial standpoint. And now that it gets more competitive and more get in. So, there are other projections where in 5 years, this is half the individual market. There's scenarios too, where I think we look back in 5 years and we say, oh my gosh, what happened to group insurance? It's flipped over. Now, again, that's the crazy prognosis from the, like the ICHRA administrator. I'm not saying that's going to happen, but if you're a carrier, you need to be paying attention to it. It's less than 1% now, but that won't stop it. And maybe it stays there, but you also need to weigh the fact that, hey, this could be a revolutionary flip in the marketplace.
Well, and I think that's a good place to end the conversation. Thanks, Jack. I would like to thank all our panelists today for the great conversation, and thank you to our attendees for joining. The next panel is a discussion with National Association of Medical Directors CEO Matt Salo and Texas's previous Medicaid Director Stephanie Stevens on how COVID is impacting Medicaid programs now and into the future. You can join that panel by going to the specific link. Thanks again, and have a great day. Thanks, panelists.
Thank you.
Thank you all.